Please start, ma'am.
Okay. Good evening, ladies and gentlemen. This is the first session of this year that neurophysiology subsection is going to held, and this is one of the most important topic, that is the ulnar neuropathy, how to evaluate, how to diagnose, and how to clinically differentiate and treat. And for this, we have the first, Dr. Murli will be describing about the diagnostic modalities of ulnar nerve at different level using neurophysiology and ultrasonography. And Dr. Dilip from Nizam will be presenting two patients with ulnar neuropathy. And subsequently, the head of department, Surya Prabha, will be discussing about the differential diagnosis and rest of the management. I request Dr. Murli to start the session presentation. Thank you.
Yeah, ma'am. Good evening, everyone. I'll share my screen. Able to share my screen. Can you see the screen, madam?
Yes, sir, perfectly.
Yeah. May I start? Good evening, everyone. So thank you, madam, for the introduction. And also, this is the first webinar of our subsection in this year. So as you told, ulnar neuropathies are very common things that we encounter in our electrophysiology lab and even in the clinical practice. So I'll just give you an outline of the ulnar neuropathies and also various testing methods, what we can do to evaluate in our day-to-day practice. I'll just touch upon in the first 3-4 slides about the relevant anatomy. You all know this is a very picture of the ulnar nerve. Ulnar nerve originates from the C8T1 roots, and it has it goes to the lower trunk and also then medial cord of the brachial plexus. And in the axilla and in the arm, it has no branches. Sometimes the branches to the FCU and also FDU, FDP can arise above the level of the olecranon also sometimes. And in the forearm, it actually gives branches to the 1.5 muscles, that is the flexor carpi ulnaris, and also the medial two digit 4 and digit 5 tendons of the FDP. And then it enters into then it gives the two cutaneous branches, palmar cutaneous branch and also dorsal cutaneous branch, and then enters to the Guyon's canal and then divides into superficial branch and also the deep branch. Superficial branch is the sensory, and the deep branch, first it supplies proximally to the three muscles of the hypothenar muscles, flexor digiti minimi, opponens digiti minimi, and abductor digiti minimi. Then it supplies the interosseous 3/4 lumbricals and also the two muscles in the thenar eminence. So with this, actually, we can can you
Dr. Murali,
yeah.
Actually, some of your slides are not audible, not visible to the some of these webinar people.
Yeah, madam. Now is it visible, madam?
No,
But
ma'am,
I could see.
slides and sir, audio is completely fine. I just check on attendee side also.
Okay. Slides are visible, no? Can I continue?
Yes, sir, perfectly slides are visible and your voice is coming out perfectly.
Okay. So that is the relevant anatomy of the ulnar nerve course. Actually, the ulnar nerve is most commonly affected at the level of the ulnar nerve at the elbow and also at the level of the wrist. So I have just put up two pictures which are very well known in the standard textbooks. The one is at the level of the elbow. The ulnar nerve passes behind the olecranon, behind the medial epicondyle, that is called as retrocondylar groove, and from there it exits and enters into the humero-ulnar arcade, which is a fascia between the two lips of the flexor, two lips of the flexor carpi ulnaris, and this is where actually we call it as a cubital tunnel. So the nerve gets entrapped just at two sides, the retrocondylar groove and also the cubital tunnel syndrome and cubital tunnel. And at the level of the wrist, actually it can gets compressed at the level of the Guyon's canal. Depending upon the branches which are at the level of the Guyon's canal, it is again divided into three or four types of entrapments at the level of the wrist. We will be actually showing, Dr. Dilip will be showing one case of the ulnar neuropathy at the wrist, so I won't go into the specifics of the Guyon's neuropathy. So many patients actually they just present with the ulnar clawing, but actually in the clinical scenario we actually have to differentiate it from the medial cord, lower trunk and CIT1. Just like foot drop is always not equal to common peroneal palsy, ulnar nerve clawing is not always equal to the ulnar neuropathy, either at the wrist or at the level of the elbow. It could be actually a medial cord, lower trunk or CIT1 root or segmental disease also. So we can actually differentiate by clinical examination by actually doing the careful sensory examination of the medial palm, dorsum of the hand, medial forearm, and also the motor examination of various muscles as shown in the picture. So first we'll go to the electrophysiological evaluation. So when you actually approach a case of ulnar nerve clawing or ulnar neuropathy in the electrophysiology lab, we have to answer specific questions. The questions that we have to answer is it just an ulnar neuropathy or a mimic? The mimic is what I have shown in the previous slide. It could be a lower trunk disease, or it could be a medial cord disease, or it could be CAT1 segmental disease or a root disease. And we also have to be able to differentiate whether it is an axonal pathology or a focal demyelinating pathology. We should be able to know the site. It could be ulnar neuropathy at elbow or at the wrist, or there could be some, all along the course of the nerve. Then whether it is a just a mononeuropathy or it could be a part of a diffuse disease also, or and probable etiology, whether it is a compressive etiology or an entrapment etiology, we should be able to tell at the end of the electrophysiological evaluation. These are the questions we should be able to answer. So there are some technical things which we should know whenever we approach a patient of ulnar neuropathy in electrophysiology. Always the ulnar nerve is the, this is a very easy to understand. We actually place the elbow position of the when we do the ulnar nerve conduction in a flexed position between 90 to 130 degrees because of the pictures that I've actually shown. If you actually fully extend the elbow, there is lot of nerve that is redundant, and the measured distance between the below elbow and also above elbow, above elbow can actually uh, will be very less, and actually it can underestimate, and it erroneously can show the motor conduction velocity which is very slowed. So that is the reason why actually we actually make the nerve taut by actually flexing the elbow to around 90 to 135 degree. Usually in our lab we do 90 degree, and that is the principle that we do, that is for these purposes. And the next thing that we should also know that there is a fascicular arrangement of the ulnar nerve. There are various, there are the fascicles which supply. This will have clinical implications also. For example, the FDA is more anterior than the ADM. So when there is any compression of the ulnar neuropathy at the elbow, the FDA may be involved earlier than the ADM. So if the motor nerve conduction comes out to be normal from the ADM, we should actually always record from the FDA also. And as I told before, there could be variations in the branching to the FCO and FDP also. And as you see here, the FCO and FDP are actually located more posteriorly at the level of the elbow when compared to the ADM and FDA. That is the reason why ADM and FDA are more affected, more wasted, leading to ulnar nerve clawing when compared to FCO and FDP. They are affected very late. And there could be preferential duct sparing also in patients with UN, ulnar neuropathy at elbow. We usually presume that when there is ulnar neuropathy at elbow, the dorsal ulnar cutaneous nerve sensation will be lost. But this is not always the case. There could be fascicular arrangement of the duct in the ulnar nerve. That's the reason why dorsal ulnar cutaneous nerve sometimes can be spared also. So this is also some of the things that we should understand before approaching electrophysiologically. So I'm just showing how to actually record the ulnar nerve various things. The first thing that we do is the ulnar nerve motor conduction study. So we have actually placed the patient's position into 90-degree elbow flexed, and we have actually put the electrodes of the recording electrode and also the reference electrode at the on the ADM, and also the reference electrodes at the metacarpophalangeal joint, and we actually are stimulating it. As you can see here, this is the live record. Um, so, so the electrodes are being shown here. So we are actually stimulating the ulnar nerve at the level of the wrist. So with the supramaximal current, so that we don't. So this is we got a 9.2. Then we record below the level of the elbow. The site below the level of the elbow recording is important because the site of recording should be usually not beyond 3 centimeters below the level, 3 to 4 centimeters. If you actually record just within 3 centimeters, then we could be missing the cubital tunnel syndrome also. Cubital tunnel, we will be bypassing that area. And we are recording proximal to this. This is the way we record the classical ADM recording. So next, so s- when we record the previous slide, when we have actually recorded the below elbow and proximal elbow, actually we see the conduction velocity which is actually slowed across the level of the elbow. If the conduction velocity is slowed more than 10 centimeters compared to the rest of the forearm segment, then probably there is a focal compression happening across the level of the elbow is what we actually presume. So sometimes actually we don't get any kind of, I mean, slowing. Sometimes we may have to do inching. This is a short segment incremental study which is being demonstrated. Actually, same recording from the ADM. And we record at exactly 2 centimeters from the below the elbow to the proximal to the elbow. Actually, if there is to see for any short segmental latency derangements. So if there is any increase in the latency, abrupt increase in the latency by zero point 0.4 centimeter for zero point 0.4 milliseconds, if we are actually testing at 1 centimeters distance or 2 centimeters distance, if the abnormal latency prolongation more than 0.7, then probably there is some amount of the conduction slowing across. This is a very sensitive and important technique. Sometimes if you do carefully, we can differentiate whether the compression is at the level of the cubital tunnel or at the retrocondylar region. But at the same time, we should also remember that if not done properly, actually it can lead to erroneous results also. This is another technique which is of very important utility in electrophysiological evaluation of the ulnar neuropathy at elbow. So this is the way we do inching. So yes, sometimes, as I told before, there could be differential involvement of the FDA because of the fascicular arrangement of the ulnar nerve at the level of the elbow. So FDA recording is always important. And moreover, whenever we actually whenever we are actually approaching a case of ulnar neuropathy at wrist, this recording of FDA is very important because we should be able to differentiate whether it is a proximal deep motor lesion or a distal deep motor pathology. This will be able to differentiate that. So here actually we have put the recording electrode and also the reference at the level of the FDI, flexor first dorsal interosseous, and we are recording as same at the level of the wrist below and also proximal. The same is being repeated. So same is being repeated. This is below the level of the recording. And again, proximal to the recording. So this is the way we actually record it. So then sometimes actually if the wasting is very severe and FCU is paired, so sometimes we may be able to record from the FCU also. So this is another type of recording that sometimes we use in our labs. And these are the sensory techniques. The commonly used techniques is the orthodromic technique. Orthodromic techniques from the digit 5 is what we use. We actually put the recording electrodes at the level of the wrist, and we are stimulating the ulnar nerve, digital nerve, fifth digit nerves. You can see the amplitude that is very well seen. This is a normal person. This is actually put it up just for the demonstrating the nerve technique, how we record. So sometimes actually even digit 4 conductions are important, especially in patients with Hansen's where only some nerves are affected, digital nerves are affected. Actually, we do an antidromic study from the fourth digit. This is a demonstration where we are actually stimulating at the level of the wrist and recording at the level of the fourth digit. This is the antidromic study of the ulnar sensory nerves, as you may see here. So I'm actually again showing the antidromic study of the fifth now. Sorry, fifth from the fifth digit. Previously, we saw orthodromic study. We are stimulating at the wrist and recording at the digit 5. So this is another type of sensory recording that we can see. This is an antidromic technique of sensory nerve conduction velocity. So this is the dorsal ulnar cutaneous nerve. Dorsal ulnar cutaneous nerve is recorded by keeping the electrodes. This is by antidromic technique. We keep the electrodes in between the first and the second, in between the little and the ring finger. And we actually stimulate around 8 to 10 centimeters proximal to the ulnar styloid process. So this is what we are doing. We are actually stimulating proximal to the ulnar styloid process. So we get a nice amplitude of the sensory nerve conduction. Usually we get around 8 to 10 microvolts amplitude. The importance of this I actually told in ulnar neuropathy at wrist. So if ulnar, we can definitely tell that if the dorsal ulnar cutaneous is paired, probably the lesion is above the level of the wrist. That we can tell. But if the ulnar dorsal ulnar cutaneous is preserved, then it may not be always. I mean, because of the preferential fascicular involvement, it could be dorsal ulnar. It could be. Sometimes it can be spared in even in ulnar neuropathy at the level of elbow. So sometimes we can do ulnar sensory inching also. This is important because sometimes the sensory nerves are preferentially first affected in ulnar neuropathy at elbow. Sometimes we don't get the motor are completely normal. So ulnar sensory inching also can be done. However, it will have its own problems that actually as we, because the potentials are very small, as we go proximally below the elbow stimulation and above the elbow stimulation, the amount of the potential that we get is very less. Sometimes we have to be careful and interpreting this investigation also, ulnar sensory inching, especially in patients with early compression across the level of the elbow. So this is at the level of the wrist. Then below the level of the elbow and proximal. So this is another imaging technique. So the other studies which are of importance, which I'm actually not showing for the want of time, is actually second lumbrical and at the same time ulnar interosseous distal motor latency. This is important in like ulnar neuropathy at wrist. This is the same test that we do in patients with CTS to comparing. We are comparing the latency between the median and also ulnar. but we should be careful that there is no coexistent carpal tunnel syndrome in these patients. So if there is a coexistent carpal tunnel syndrome, this test can be definitely fallacious. And mixed sensory studies also in early ulnar neuropathy at elbow is important. And we can do inching across the wrist also. 1 centimeters, 3 centimeters proximal to the wrist distal wrist crease and 4 centimeters distal to the distal wrist crease. We can actually look 1 centimeter and also see if there is any focal slowing across the level of the wrist. And we can, this is very technically demanding. So the simple test that we can do is to demonstrate slowing across the wrist by just stimulating above the wrist and also the palm stimulation to just to see if there is any conduction velocity slowing across the ulnar neuropathy at the level of wrist. So then the EMG protocol is fairly simple. We have to do the I mean, the ADM and FDA EMG, FCO and FDP EMG, and to also rule out the lower trunk pathology and the C8 root. So these are the muscles which are supplied by the C8 roots, that is EIP, FPL, EMG, which we can differentiate the lower trunk from the core ulnar neuropathy. Sometimes, despite all these things, non-localizable NCS and EMGs are very common in the evaluation of ulnar neuropathy and elbow. In such cases, neuromuscular ultrasound is definitely of value. Now, coming to the next modality, always neuromuscular ultrasound has to be used in tandem with the electrophysiology. They are complementary techniques. It is of very much useful when it is non-like localizable, and we cannot actually tell the etiology, especially when we are doing electrophysiology, and to identify the exact site of the disease. And subluxation, ulnar nerve snap, and even tricep snaps, these are very common, and these snappings are actually better demonstrated by the neuromuscular ultrasound only. What do we see in neuromuscular ultrasound? We see the cross-sectional areas at various sites. We can see at the wrist, we can see at the mid forearm, we can see at the level of the elbow, below the elbow, proximal to the elbow, even in the axilla also. And to just make a point that patient himself is a controlled, swelling ratios are very important. We can actually measure the ratio of the at the level of the elbow to above the level of the elbow to see what is actually happening, how the ratio to see the focus, I mean the ratio. And we can see the mobility, as I have told, that by dynamic ultrasound. Fascicularity, whether the fascicles are distorted or partly effaced or fully effaced. And vascularity, if there is intraneural vascularity, we put the power Doppler and see if there is any infective neuritis or vasculitis also. I'm just showing a demonstration, and the cases will be followed up later by Dr. Dilip. So this is a demonstration. I'm actually demonstrating the ulnar nerve in the arm segment. As you can see, the nerve which is actually being traced proximally, this is the triceps muscle. The pointing that I am putting is actually the ulnar nerve. I am tracing proximally. So you can see the axillary artery also here. So the ulnar nerve going proximally till the level of the artery. I'm actually tracing from the medial olecranon till the level of the axilla. And I'm again coming down. So here, this is the radial nerve which is going there. And this is the medial ulnar nerve. I'm pointing out. It is, as you can see, this is just the subcutaneous tissue, and the nerve is quite superficial proximal in the arm segment. So coming to this is the olecranon, and this is the arm segment. And coming to the forearm segment, this is the forearm segment. You can see the FCU. FCU is the one which has a central tendon, which is actually seen. And now in the mid forearm, we are actually, it is close to the ulnar artery. This is the ulnar artery. This is the ulnar nerve. And it is going, see, you can see the dorsal cutaneous nerve leaving, and we are coming till the level of the wrist. So this is the way we actually do. So next, at the level of the wrist, actually, this is the hamate bone that you can see. So the nerve is being traced proximally. So proximally. So that's all. Actually, the ulnar neuropathy, I just touch upon the reasons. These are all the reasons which will be discussed in the next sessions. The retrocondylar groove and also the cubital tunnel compression. There are various causes. And at the same time, ulnar neuropathy at wrist, it could be occupational, it could be tumors, it could be anomalous muscles and other things. So this is the way we evaluate electrophysiologically and by ultrasound. And that's all from my side. Thank you.
It's a nice presentation, Murali. Can you tell something about that? How you will differentiate medial cord and the sensory distribution, either clinically or from the ulnar neuropathy,
Yeah,
for the
ma'am.
people's sake?
Actually, patients who have medial cord pathology usually will have the sensory disturbances in the medial forearm also, madam. Actually, like we see, especially in TOS patients, thoracic outlet, and in some forms of brachial plexopathies also. If there is any sensory disturbance in the medial forearm, that is the MAB, that is medial antebrachial, which also comes from the medial cord. If that is abnormal, then we should think that it could be either trunk or it could be medial cord. We actually suggest them to record the medial antebrachial cutaneous nerve snap also.
Okay, okay. Actually, and sorry for the disturbance. I want to ask one more thing, that anything about this Martin Gruber anastomosis?
Yes, ma'am. Actually, Martin Gruber, it is like something we actually see the conduction block across the level of the elbow is what actually we are interested in ulnar neuropathy at elbow. But when we are doing electrophysiology, when there is any conduction block between the level of the wrist and below elbow segment, then always we should think that there could be Martin Gruber. That time actually it is wise to record stimulate the median nerve at the level of the cubital fossa and recording from the ADM or FDA. If we actually record, if we get a good potential, probably there could be Martin Gruber anastomosis in some patients. So if there is a block in the forearm segment between the distal two stimulatory sites, then we should think of Martin Gruber.
Okay, it's a nice presentation. And may I ask Dr. Dilip to present his cases? I didn't. So there are certain questions. Shall we take the questions at the end to both?
Yes, ma'am. Yes, ma'am.
Okay, okay. Dilip, please go ahead.
Is my screen visible, sir?
Yes, it is visible.
Yes, sir. Yeah. Good evening, respected faculty. This is a case of a 45-year-old male, businessman by occupation, alcoholic, with no comorbidities, presented with minute, sir. Is my screen visible? Only my face is visible, sir.
No, even screen is also visible.
Your screen is visible, sir.
1 minute. Yes. Presented with reported with gradual onset of weakness in his left hand in the form of difficulty in gripping objects, and later he noticed difficulty in buttoning his shirt for the past 6 months. He also reported thinning of the left hand for the past 1 month, predominantly affecting the little and ring fingers. There is no weakness around the elbow and shoulder joint. There is no weakness of the right hand and the lower limbs. There is no sensory complaints, no fasciculations, no neck pain and shoulder pain. There is no complaining of trauma also. Past history, he is not a known hypertension, diabetic, thyroid disorder, rheumatoid arthritis, CKD, or prior any elbow fractures. Coming to personal history, he takes mixed diet. Occasional alcohol intake is there. Family history, no history of similar illness in the family. There is no history of inherited neuropathies in the family also. Drug history, there is no history of any neurotoxic or chemotherapeutic drug intake. Coming to the physical examination, on general examination, patient there is no proper on general examination. It was unremarkable. On nervous system examination, there is no peripheral nerve thickening. On cranial nerve examination was normal. On motor examination, there is a wasting of the hypothenar muscles on the intraossea on the left side. The tone was normal. Power examination, I will show the videos next. On power examination, there is a weakness of the hypothenar muscles on the intraossea on the left side. And there is normal power on examining the flexor carpi ulnaris and the FDP muscles. Deep tendon reflexes are intact, plantar being flexor. Sensory examination was not normal in both the upper limbs and the lower limbs. There is no other neuroaxis involved. Tenel sign is negative in this patient. This is a clinical photograph of the patient in which there is a Wartenberg sign on the left side and right, it was normal. This is the same patient which shows a Wartenberg sign on the left side with the mild asymmetry when compared to the right on the left hypothenar muscles. This is the examination of the patient. On the right ADM, it was good. On the left ADM, it was weak when compared to the right. Along with this FDI on the right side, which was normal. On the left side, the FDI power, it was weak when compared to the right side. So with these complaints, we have done the NCS for this patient. Here, the amplitudes of the left median.
Dilip, what is your thinking? You are thinking about the case. What level and what you are thinking?
Yes, ma'am. As the patient has only motor weakness involving the intraossei and the ADM, there is no sensory involvement involving the any digits or in the palm. So it can be distal, maybe at the level of wrist, maybe distal to the level of wrist, because sensories all are normal. Only complaint is motor involvement that is involving the interossei and the hypothenar muscles. So most probably the lesion should be at the level of ulnar nerve, which is distal to the level of wrist, ma'am.
Then how you will differentiate it from the other DDs like medial cord and other things in this patient?
Yes, ma'am. As the patient has no other sensory complaints and the other examination, the medial nerve innervated CIT1 group of muscles, that is APB and the FPL is normal, along with EAP was normal, which is separated by the CIT1 root. Along with if the patient has any lesion in the medial cord, there can be involvement of the medial brachial and medial antebrachial cutaneous nerve, which will suppress the forearm group of forearm muscle. Along with here the sensory supply, which is affecting which is separated by the dorsal cutaneous and the palmar cutaneous nerve is also normal, ma'am. So sensories are intact with the other group of muscles separated by the CIT1 are normal. Only group of muscles which is ulnar pyramid, that is in the hypothenar and intraossea affected.
So you are saying that the group of that is median motor and the muscles innervated by the median nerve distribution was not involved in this patient. So the thenar muscles are not involved only because hypothenar muscles are involved. So in addition to the sensory being intact in the forearm, you are not thinking in the form of medial cord in this patient. And what is you are thinking it is only ulnar distributed muscles were involved, and though the sensory being not involved, that is the odd in this patient, and the patient had weakness followed by the wasting rather than wasting followed by the weakness. So that's why you are thinking more towards the ulnar nerve than to
Distal,
okay.
which is distal to the wrist, I am thinking, ma'am. So nerve conduction studies for this patient was done, which shows the amplitude of 8.9 in the left median and the latency was 3.7, which was the normal range, with a velocity of conduction velocity of 57 and FAV latencies being also normal. Right median, the amplitudes are in 7.1 and the latency is 4, along with the conduction velocity and FAV latencies are normal, which is normal on both the left median and the right median. Coming to the left ulnar nerve, regarding the ADM muscle, the amplitude is 1.25, which was reduced, and compared with the right ulnar also, the value is of 9.4. When compare this right ulnar radium with the left ulnar radium, there is a significant drop in amplitude which is more than 50%. Along with the latencies is of 4.5 in the left ulnar. In the right ulnar, it is 3.1, which shows there is a decreased amplitude along with increased latencies. Here the velocities and FAO latencies being normal in the left ulnar nerve recording using the ADM muscle. When we recorded the left ulnar in the FDI, the amplitude is 4.5, which is below normal, which is of a near range, but the latency is 6.7 in this group of muscle, that is FDI, by checking the ulnar nerve. When compared to the right ulnar FDI, the amplitude is more than 50% decrease, ma'am. Here 19 is the amplitude. Here it is a 4.7 when compared to right and left, which is more than 50%, which is significant. Along with the latencies, here is 6.7 and the right ulnar it is 3.2. And the velocity is being normal, that is 52. These are motor conductions. These are graphical graphs of the left medial at the level of wrist and the left medial at the level of elbow, which shows normal waveforms. In the right median and the right medial at the level of wrist and the right medial at the left elbow also, the waveforms are good. When eliciting the left ulnar at the level of wrist in the ADM, there is a decreased amplitude and there is increased latencies. Along with when recording the left ulnar below the elbow and above the elbow, there is a significant decrease in the amplitudes on the left. When it is compared with the right ulnar at the level of wrist and the level of elbow, below and above elbow, the waveforms are good. And the right ulnar below at the level of wrist, below elbow and above elbow, the waveforms are good and the latency and amplitude is normal. These are the sensory conductions of the patient. We shows comparing the right dorsal ulnar cutaneous and the left dorsal ulnar cutaneous, which is of in the same range, that is 8 on the right and the left it is 7, with the velocities being normal. When checking the left median, right median, it was a normal range, that is 21 and 26. There is no significant difference. When we examine the left ulnar and right ulnar at the level of wrist, there is no significant changes in the left ulnar also. This is
So what is the inference you are getting? At what level? Can you summarize your conductions in this patient? What you are thinking about this patient?
Ma'am, in the patient, as the left ulnar ADM and FDI is affected in the motor conductions, in this ADM is more affected when compared to the FDA. Along with in the sensories also, there is no significant changes, ma'am. When comparing the right and left, both are in the normal range. Like is left ulnar and right dorsal ulnar cutaneous. Along with medial and ulnar also, it was a normal range.
So you are saying that sensory is totally spared, either by the dorsal cutaneous nerve of ulnar or palmar cutaneous. Both are normal in this patient with the preferential involvement of ADM and also FDI was there, which are actually presented in the anterior location. So, but if it is at the elbow location, even if you see the fiber distribution also, the sensory has to be involved if it is at the elbow.
Yes, ma'am.
And you didn't find any drop, but you found the block at the distal. That's why your distal latencies and amplitudes were down rather than conduction velocity in this patient. So it shows there is a distal block rather than the anterior, proximal block. So fine.
Yes, ma'am. This is the ANMG of the patient showing the left ADM, which shows there is a in spontaneous activity regarding this 50 microvolts per decision. Along with 10, there is a spontaneous fibrillation potential there with a few recruitable MAPs in the left ADM. We have recorded FDI also, which shows the same like spontaneous activity is there. After this history and nerve conduction studies, probable history, it is involving the left side of the ulnar, which is motor predominant, with the side which is at the level of wrist or distal to the wrist. And the type is severe axonal based on the NCS, and the probable etiology may be entrapment at the level of wrist. In this patient, we further done the ultrasound of the nerves. This is the ultrasound picture of the patient. Here it is at the level, it is above the level of elbow near the axilla. Here it shows the axillary artery. Beside is the ulnar nerve. This is when we trace down. This is below the above the elbow, but above the elbow, below this level of axillary artery. Here the ulnar nerve. Here in the first section, the cross section is around 5 millimeter square. Here the cross section is around 6 millimeter square. This is at the level of elbow, just above the level of elbow. Here it shows the humerus bone along with the ulnar nerve, which has a cross section area of around 6 square. This is at the level of elbow with medial epicondyle. This dotted area is the ulnar nerve, which shows an area of around 7, which is in the normal range. This is below the level of elbow. Here we are seeing this ulnar nerve. Above is the flexor carpi ulnaris. Here it is the FDP. Here it is the FDS. This is at the level of mid forearm. Here ulnar artery along with ulnar nerve is visible. Here the cross section is around 5 millimeter square, which shows a branching along with branches to the dorsal cutaneous branch has been started here in the mid forearm. This is the cross section area at the level of wrist. Here the ulnar artery and ulnar nerve is being shown. Here this is the pisiform bone. This is below this level of this is below this cross section at the level of wrist distal. Here there is one cystic lesion compressing the ulnar artery along with ulnar nerve, which may be at the level of Guyon's canal. Here I am showing video. Here ulnar nerve is traced from above the axilla to the below. Here this ulnar nerve is from the above. Here, yes. This is at the level of elbow. Here ulnar nerve is there above FCU, this one FDP and FDS. This at the level of mid forearm beside the ulnar artery, and now to the ulnar cutaneous is also given. When we trace distally, this is going near the level of elbow here. 1 minute, I will pause and show. This is above the elbow, which shows here it is the ulnar nerve. When we trace down slowly, from above elbow, from the axillary artery, we are tracing down. This is just above the level of elbow. This is at the level of elbow, and we are crossing the radial groove, and we are going into the cubital tunnel. Here, this is at the level of FCU and FDP and FDS in the below elbow, and this is a mid forearm section which shows the ulnar nerve and ulnar artery and giving branch to the dorsal cutaneous in this. Along with, when we go distally, it enters near the level of wrist here at the level of at the level of Guyon's canal. There is cystic lesion here. At the level of Guyon's canal, there is cystic lesion which compresses the ulnar artery and the ulnar nerve. So this cystic lesion can lead to the only pure motor complaints in the ulnar nerve maybe. From the ultrasound, from the final conclusion, side is confirmatory on the left side with the side maybe at the level of wrist. Probability because of this cyst, this patient has only pure motor weakness. This is because of this Guyon's canal anatomy. Here, this Guyon's canal is formed by pisiform bone and hook of hamate on the lateral. Medial it is from the pisiform bone. Roof is formed by the volar carpal ligament. Base is formed by the transverse carpal ligament. Here, the contents like ulnar nerve and ulnar artery will be there. if any lesion or any etiology affecting this ulnar nerve at the level of Guyon's canal, it will compresses and it will cause the ulnar neuropathy. Based on the site of the lesion, this Guyon's canal types can be around 4 types. First, it is compression of the ulnar nerve in the proximal part of ulnar canal. It has both sensory and motor weakness. In type 2, there is compression of the deep profound branches of the ulnar nerve, that is in the motor part. This is the motor part in the proximal part. If it is if it is affecting the here, that is in the type 2, patient will have both thenar and intraocular weakness. If it is affecting in the distal part of the muscular branch, that is here, there will be sparing of hypothenar muscles and only intraocular will be affected. In type 4, there will be only superficial ulnar branch affected, only sensory sensations will be lost. Remaining all will be normal. So from this history and NCS along with the ultrasound, this patient is having the ganglionic cystic lesion, which is present in the Guyon's canal, compressing around the second part of this deep proximal deep part of the ulnar nerve. So the patient has both interossei and hypothenar muscle weakness, sparing the sensations, which is both which is supplied by the superficial part along with the dorsal cutaneous and medial antebrachial parts are not involved.
So it's a wonderful presentation, Dilip. And your case shows how clinical examination helps in localization, followed by it is being supplemented by, though electrodiagnostic will help, doing the ultrasound will you will know the etiology, and also you can direct at the treatment part of it. So this shows how ulnar nerve is passed, and how sometimes doing the dorsal cutaneous nerve and palmar cutaneous nerve is also important in doing these kind of things. And the needle also will help. And your EMG is showing actually continued activity. So that fibrillations and fasciculations are there, which are showing the ongoing compression and ongoing denervation. So that's why in order to have the grip, the patient should undergo some procedure for this.
Yes.
So that's the moral of this case.
Okay, may I comment something? Okay. Hello. Can you hear me?
Yes, ma'am.
Okay, it's a beautiful case because this case is usually rare. Deep ulnar neuropathy you don't see more commonly than your ulnar neuropathy at elbow. And clinical clue was that he had normal sensory function.
Yes, sensations.
And electrodiagnostic clue was that his sensory conductions were normal, but you had abnormality in FDI and ADM. That is the reason you can see that it is at the level when the sensory nerve fiber already exited only the motor fiber, but ADM is affected because ADM is given by the deep branch first branch. So that probably clinically you can localize, but etiologically definitely ultrasound helped you that it is a ganglion which can be removed and he will be better off. So this case illustrates that when you examine a patient, probably it is very, very important to examine clinically whether the muscle, if it is ADM is affected, small muscle, specifically ulnar innervated muscle and sensory is normal. The question raises whether it is a Hirayama disease or it is a ALS to begin with, because it is a pure motor. So sometimes in Hirayama, your hypotenar is more affected than the tenor group. So in that situation, it might be a little confusing. But but did he have pain at the site of ganglion when you palpated his ulnar nerve at the palm? Suppose when you got this wasting, did he have any pain at this local site when there
This
is
patient
ganglion?
don't have pain.
What was his job?
Ma'am, he was businessman, ma'am.
Businessman. So he doesn't do any manual work that
No,
when the
ma'am.
ganglion will compress that he will have tingling sensation and
No, ma'am. He's businessman
exacerbation
by
of the
occupation, ma'am.
symptom. Okay, so probably that is another important point. If it is a compressive pathology, then if there is a ganglion or any other thing, when he does the manual work, either by anything hard object he will hold or do, then there will be a pain. And specifically the people does those sorts of things, they are more vulnerable for injury to the deep ulnar nerve. It's a beautiful case, not commonly you see. So, but probably clinical clue and that etiological confirmation either by ultrasound or by MRI that can help you. Because if it is a, how will you differentiate from, suppose to begin with it is just a Hirayama disease. How can you differentiate Hirayama disease from your wasting of your distal hypotenar FDI? So how can you differentiate?
Ma'am, because this patient have only ulnar nerve distribution that is in the
We cannot say
elite.
ulnar. Oh, okay. Your motor wasting is ulnar, but similar may look like if it is a Hirayama disease to begin with, he may have only small muscle atrophy hand with hypotenar more involvement than the tenor. Then you have to see whether other myotomal innervation on EMG is affected or not. Like if it is a Hirayama disease, you will get beyond that your EMG restricted to the ulnar branch of the deep ulnar branch, ADM, FDI. But in Hirayama disease, you will get neurogenic changes in APB, in extensor digitorum communis, but brachioradialis will be spared. So this is the way probably even in clinical finding an EMG, you can localize, and definitely here your ultrasound helped you to etiological diagnosis, what is the cause of deep ulnar neuropathy. Thank you very much. You can go ahead with the second case.
Yes, ma'am. Ma'am, this is a 42-year-old male, driver by occupation, with no comorbidities. Initially have a reported pain in the right elbow region. 1 month later, he started noticing to have tingling paresthesias in the right little and ring finger, involving both dorsal and palmar aspect. Initially started in the tip of finger, it's progressed up to the wrist region. There is no further extension into the forearm. The sensory complaints is restricted up to the wrist. There is no weakness or wastings or any fasciculations in this patient. There is no other sensory phenomenon. There is no history of neck pain or shoulder pain in this patient. There is no history of trauma. Past history, not a known patient, not a known case of hypertensive, diabetic, thyroid disorder, rheumatoid arthritis, CKD, or any prior elbow fractures. Coming to the personal history, he takes mixed diet and occasional alcohol intake. It is there. Family history, there is no history of similar illness in the family. Along with there is no history of inherited neuropathies in the family also. Drug history, there is no history of neurotoxic or chemotherapy drug intake. Examination, general examination was unremarkable. Nervous system examination, there is no peripheral nerve thickening. Cranial examination was normal. On motor examination, bulk, tone, power was normal. Along with deep tendon reflex was intact, plantar being flexor. Only sensory examination has shows significant changes, which shows there is decreased pain sensations over the dorsal and palmar aspect of the fourth and fifth digits and up to on the medial palm up to the wrist region. There is no further loss of sensations in the forearm group. Tinel sign is positive at the elbow in this patient. So history-wise, there is only pain in the elbow region followed by sensory involvement involving the fourth and fifth digits. There is no motor weakness. On examination also, motor involvement is not there. Only sensations is affected with tinel sign being positive at the elbow. These are nerve conductions of this patient. Here the sensory conductions, comparing the right and left medial nerve, it was in the normal range, that is in the 33 and 25, and the latency is also normal. In right ulnar, it was reduced when compared to the left ulnar, which was more than 50% reduced. In the motor conductions, the Cmaps of right medial and left medial was normal, with latencies being in the normal range. But in the right ulnar recorded using the ADM, at the level of wrist, the amplitude is 4.8. At the below the level of elbow, there is 3.7. When it is checked at the above the level of elbow, it is 1.7. There is significant drop in this amplitude in below and above the level of elbow. Along with the latencies is also increased, 6.88 to 11.61. Along with the conduction velocities, below the level of elbow, it is 55 and above it is 17. There is significant drop. When it's compared to the left ulnar using the ADM muscle, the amplitudes are in the normal range and the latency is the normal range with the velocities being the normal. The F-wave latencies in this patient is prolonged on the right side when compared to the left. These are the NCS graphs of the patient. Here the right median amplitude and latency is normal. Along with the right ulnar, this patient has a significant drop in the amplitudes below and above the elbow. Along with there is a significant drop in the conduction velocities. This is the left median and left ulnar, which was normal. Here the right ulnar, the FAO latency is prolonged. When compared to the left, it was in the normal range. These the right ulnar sensory conductions. Here it is decreased. In the left, it was normal. This was the left ulnar and the left median. After this history and NCS, patient is having right NCS wise there is a sensory motor involvement with history only side of sensory involvement. On the right side only ulnar nerve is involved. Sight is being probably across the level of elbow. Type can be due to focal demyelination at the level of elbow. Proper pathology can be entrapment. Further, in this patient, ultrasound is done. Here, this is at right ulnar at the level of above the level of elbow. Here, the cross section is around 6 mm square. This is a right ulnar at the level of elbow. This is a medial epicondyle. Here, the cross section area of the ulnar nerve is 13, which was on the higher side. This was the right ulnar nerve below the level of elbow. That is below this FCU. Here the cross section is around 11, which was in the higher side. This cross section, this ulnar nerve ultrasound showing at the mid forearm level beside the ulnar artery. Here the cross section is around 8 mm square. This is at the level of wrist. Here along with the ulnar artery, the ulnar nerve is there. Here the cross section is around 5 mm square. This is a video. Here we are tracing the ulnar nerve from below to above. This is at the level of mid forearm, where it is along with the ulnar artery, giving branches to the dorsal ulnar cutaneous. This is below the level of elbow. Here, on entering through the cerebral tunnel, there is a cystic lesion present here, which is compressing the ulnar nerve. This lesion is extending below the level of elbow to the level at the level of elbow. Above the level of elbow, here the ulnar nerve was normal. When we trace this ulnar nerve above, high above the elbow, this was in the normal range. Here it is. It is the axillary artery. So this patient, when we trace this ulnar nerve from below to above, so it was normal below. It was normal till the level of mid forearm after giving dorsal ulnar cutaneous. Below the level of elbow, on near the cubital tunnel, there is a cystic lesion. Here there is a cystic lesion which compresses the ulnar nerve, which compresses ulnar nerve at the level of elbow, and at the above the level of elbow, the ulnar nerve was normal. This was the same patient which was traced from above to below. Here this ulnar nerve, when we trace it from above to below, this is above the level of elbow. This is at the radial groove. When we trace this below this elbow, here the cystic lesion is there. Cystic lesion is there, which compresses the ulnar nerve below the level of elbow, and in the mid forearm sections, the ulnar nerve was normal, giving a dorsal ulnar cutaneous, and the level of wrist also. This was normal. This is a cystic lesion which shows measurements of around 13.7 mm by 7.3 mm, which is significant, which is compressing the ulnar nerve at the level of elbow. This is the right medial nerve, which was conducted on the same side to look for any abnormality. Here, the right medial nerve was normal during the course below to the below elbow up to the wrist region. After ultrasound and NCS, here it is a right ulnar sensory motor neuropathy based on the NCS. In ultrasound, it is a right ulnar nerve. So in NCS, we thought it is across the elbow. In ultrasound, we have pointed this lesion which is affecting is just below the elbow, and it is affecting at the level of elbow also. The probability is ganglionic cyst at the below the level of elbow. So with the history and NCS, we thought this is any focal demyelination at the level of elbow region. But after doing ultrasound to know the etiology, this patient has ganglionic cyst which is occurring below the level of elbow and extending up to the elbow, which is involving more of a sensory in this patient, as motor is normal in this patient, maybe due to differential fascicular involvement, as the sensories are more predominantly affected in the ulnar nerve at the level of elbow when compared to the motor. So this is a case of ulnar neuropathy, which is due to ganglion cyst at the level of elbow.
So nice case. This both there is a confession that the both cases were given by actually Dr. Murali, and he has given us the opportunity to present here. And our residents are learning a lot in this. And these are two contrast lesions. One is at the any lesion around the elbow showing the conduction blocks. Usually we think of tardive ulnar palsy unless we do the ultrasound and we see the exact pathology. Sometimes it is very difficult. Actually, ultrasound made the entire treatment of these kind of things very easy. And once again, thank you, Dr. Murali, for giving us this opportunity.
May I ask one question, please? Okay, so what I think, this patient presented entirely with sensory symptom, isn't it?
Yes,
Motor was normal, isn't it?
yes, yes, ma'am.
Okay. Then you are having, on the other hand, compressive pathology at elbow. So how can we explain? Because usually motor fibers are more larger fiber. So any compressive lesion should affect the motor symptom. They should have associated weakness at least. So in this situation, is it the cause, or it is just a bystander and he is having ulnar neuropathy because of something else? That raises questions. Because any compressive pathology, the larger myelinated nerve fibers are more commonly affected. They will have at least along with sensory symptoms. But here your sensories are affected and motor is entirely normal. So, do you want to review your diagnosis and work up for further details regarding the ulnar sensory neuropathy, or you want to just go and treat this patient like this?
When it is when it, any cystic lesion, when it is compressing the ulnar nerve at the level of elbow, sensory complaints and will be more compared to the motor, ma'am. When it is at the level of elbow, motor will be predominant. At the level of wrist, motor complaints will be predominant, but at the level of elbow, mostly patients will present with the sensory complaints than the motor. Along with there can be a mostly differential involvement, I thought, ma'am, because of this sensory involvement, which is most common site for this sensory involvement at the level of elbow.
No, if I may answer that question, madam. Actually, this patient had a tunnel sign. He actually had pain at the level of below the level of the elbow. That is a site actually where the patient had pain. After some days, he presented with sensory. When we examined, there was very subtle motor deficit, madam. Even electrodiagnostics also, if you see, actually the CMAP amplitude was 4.2, I think, 4.2 on the affected side. So I think this is not a bystander and it is implicated and patient had elbow pain, pain at that site actually. 4.8 compared
That's
to the
right.
right
If we
side
had, you
13.6.
have to compare. Actually, your motor conductions, if it is CMAP was reduced on that side, then it's okay
Mm.
because purely sensory, because of a compressive entrapment pathology will be very, very unlikely. Because
Even
if it is CMAP is reduced on the affected side, then you can attribute. And
mm,
secondly, after your decompression, if his symptoms improve, that will be another take on that your diagnosis is correct. Because whatever he was showing, it is a purely sensory. That is the reason I have raised these questions.
the electrodiagnostics, if you look at 13.6 on the left side, right side it is 4 point. There is definite
And he
asymmetry.
should then that presenter should say that there is gross because it is more than 50% reduction in amplitude.
Yeah.
That means you are at least, although the power little affected, but your conduction wise you are having great reduction of more than 75% reduction in amplitude. In that case, it is a sensory motor, predominant sensory. That is what it is. Okay, that's right. Okay. Okay, you can carry on. Okay.
There are many questions, madam. We can answer them. So, if I may answer, actually, um, why is it, if I can answer, why is it focal demyelination in the second case when when the both cases the pathology is the ganglion cyst? Yes, second case probably, I mean, that is more of an electrophysiological diagnosis, madam. There was actually demyelination, I mean, in the form of the I mean, conduction slowing and block across the level of the elbow. That's why actually electrophysiologically it is focal demyelination. Sensory fibers are largest in diameter and hence in yes, that's what actually we were thinking. And is it possible to visualize the Martin Gruber anastomosis in ultrasound? No, I don't think so. Actually, the nerve fibers are very thin. I mean, at least in the whatever cases that we have seen, there is we cannot visualize the fibers. The connecting fiber very small. Why should the patients with ulnar pay? Yes, this is an correct. Usually, they will not have difficulty in holding objects, but I mean, with whole hand, if they still they can have difficulty in holding because there are some thenar muscles which are in the supplied by the ulnar neuropathy. What degree of the flexion, sir, as sir was asking, usually 90 to 135 is what tells sir. Usually in our lab, we use 90-degree flexion. And electron diagnostically non-localizable ulnar neuropathy is very common. Yes, actually, yes, sir, it is common. Many times people just come with just absent CMAPs, very late presentations. But however, actually to label it as electrodiagnostically non-localizable, we should do all types of conductions. If it is very early, we should do the sensory inchings and we should do sensory, mixed sensory also sometimes. We should do all types of sensitive techniques, then only we localize. Actually, what we can tell that is usually the ulnar nerve has no branches in the arm. If it is high up in the arm or if it is in the proximal arm, sometimes it becomes non-localizable. Otherwise, by EMG, we can localize reasonably well. um, yes, and we should do all types of sensory conductions to do. Is it possible to get a dorsal ulnar cutaneous snap? But no, yes. Actually, dorsal ulnar cutaneous can be preserved, especially in patients with MNMs, especially in Hansen's. Digital nerves are more can be affected alone, and dorsal cutaneous can sometimes be spared. So this is possible. That's in MNM also. Don't we go proximal to distal in inching method? Correct me as usually we do from distal to proximal in inching method. What we look at is about the latency that we actually sudden latency drop that we do and amplitude drop. It is actually wise to actually look at this because of this from distal to proximal. And there
Not
are, I
only
think,
that,
yes,
it is we do that because the nerve will be going deeper when we
yes,
go
ma'am.
proximal. So the difference between the proximal to distal is not only because of that, it is because of the depth of the nerve also. So in order to know exactly what is happening, it is better to do distal to proximal rather than proximal to distal.
Yes, ma'am. And there are another two questions which I missed. Can ultrasound bypass need for EMG? No, no. Ultrasound is always should be used as a complementary technique to the ENMG. So both are complementary. Even if you look at Shapiro, both ultrasound correlation with ENMG is what is actually mentioned. especially in brachial plexus injuries where EMG is still considered as a medico legal, but it cannot bypass it. It is used as a complementary technique. In a case like this, so yes, sir, actually the case which was the first case, yes, the EMG of all the nerves was actually not shown. Sometimes, no, actually the cases were picked up from the clinic. So, I mean, when we actually see first time the lab ultrasound is there, we first scan the nerve and we find some abnormalities. Sometimes we actually not do complete nerve conductions. Actually, in the case like first case, we should have done the snap potentials, snap inching also, sensory inching also. And we should have done FDP and FCU, all those things also. We expect them to be normal. Um, um, Yes, sir. I think I answered most of the questions. Normal ultrasounds are special for nerves. The nerves, the technique is what actually the delegate is asking. The ultrasound, the nerves, deeper nerves, actually we use a probe which is actually 15.4, or I mean lower, even at 12 also we will be able to understand the deep nerves. Superficial nerves, you should use a higher frequency probe, preferably 15 and above. So higher the frequency, we will be able to see more smaller nerves. Like even we can see the map, lateral antebrachial and medial antebrachial and other things. Protocol for ulnar inching at the wrist, yes, the ulnar inching at wrist usually, but this is very technically demanding technique. Yeah, the simple way to know whether there is any conduction slowing across the wrist is to find out, that is to stimulate proximal to the wrist and in the palm and see. But ulnar protocol at wrist, there are standard techniques. We actually do 1 centimeter inching, around 4 centimeters, 3 centimeters proximal to wrist to 4 centimeters proximal to the distal wrist crease. So with incremental stimulations. So if I have answered any questions also, we welcome to answer.
Thank you, Dr. Murali and Shiroprabha. It is a nice session, and the questions are relevant. So that's right, what Murali was saying. First thing, you have to localize the site of lesion. Any neuropathy, you have to mononeuropathy, you have to localize where is the site of lesion by clinical examination and electrophysiologically. After that, to know the etiology, you can do the rest of the investigation, either MR neuronography or ultrasound, so that if there is surgically operable conditions, you will be able to know it. The same thing in leprosy, you will get a skin lesion, thickened nerve, then you may not go with anything and you can just directly treat them. So this is a beautiful illustration of both the cases. One is with deep and another is your neuropathy at the level of elbow because of compression. And I think this is a nice beginning. And I thank all of you for participation, and we should interact in future. And we will be organizing the clinical neurophysiology conference on 27, 28 and 1st of March. All of you are invited and join actively, and otherwise there will be a lot of sessions. Both the speakers will be coming, and all the participants, I invite all of you to Lucknow. Thank you very much. Probably we can close the session. Thank you.
Thank you very much.